Hello and welcome to Move to Improve. I'm Dr. Matthew Jurgis. I have with me
Dr. Alex Fitzowich.
Greg Guchaz.
All right, so today is honestly a super valuable episode because what I want to do today is bring to our viewers a more intimate understanding of injury, understanding the nuances of coming back from injury, and when is it the right time to return to sport, return to play. This is something that everybody can improve upon, literally everybody, because this information is not super accessible, and it really takes some time to fully appreciate and understand as you have kind of dealt with injuries throughout your life and you get a better sense for it. And I can tell you right now that there is always something you can be doing in every stage of injury to create a better outcome for yourself in the long run. So shall we start with the criteria?
Yes. You're looking at me.
Right.
Okay,
Yes.
so you want criteria to return to sport?
Okay, let's list it for them.
The whole timeline. What are we looking for here?
Well, let's start at the end point. Is that what you're asking? The end
we
point is
want.
Return to sport. So, little Johnny goes into the doctor, with mom, and mom's saying, "Okay, well, he rolled his ankle. Can he go back and play soccer this weekend?" And oftentimes, if the doctor isn't educated on return to sport criteria, they're like, yeah, if he feels better, like they're basically making an educated guess.
Yeah, on a subjective report here.
Yeah,
from a kid,
if he's feeling
basically.
better, but that,
Or
once you get it,
they say 4 to 6 weeks.
or 4
which
days,
is
that's right,
not
which is very common,
more common.
and that's more,
And that's vague.
and it's lowest common denominator type thing. But as you become more expert in what you do, and if you deal with it every day, you know all the criteria for return to sport, right? You've learned this, you've implemented it. So, number one, time constraints for healing need to be observed based on whatever injury that is. Full range of motion, full painless range of motion, strength 95% of the opposite limb, no recurrent swelling, no recurring instability. Psychologically ready, they want to feel they're ready to go as well. Yeah. And they've gone through the necessary training in their sport sub-maximally in order to feel that they're comfortable playing that sport at maximum. So put those all together. Okay, do they have full range of motion? Are they strong? Do they feel like they're recovered? Have the time constraints? Somebody might go, I feel great, but the time constraints haven't.
It's just impossible.
And I can tell you, we'll go through some stories with that too, like even at an Olympic level. But they've gone through some significant rehab and they're like ready to go. I'm like, time constraints haven't been met. And just, I have athletes and parents signing off, medical release saying, listen, if this is against medical advice, you're going back. And lo and behold, the athlete fails. But
yeah.
So those are the criteria.
And that for our everyday listeners, that sounds like a lot. And we're going to spend the rest of this episode to kind of break down so you can kind of more intimately understand. But I think one of the driving points here is, well, first of all, these are general principles, and your injury might have some more specific criteria that you should maybe be aware of if you're suffering from it. But secondly, the idea that pain and your subjective feeling of injury is not enough to know what state of the injury you're in, because it all depends on how much you're provoking the injury. And when you are healing throughout that rehab process, if you're not getting it treated, if you're not having it rehabbed, you're not stressing the injury throughout the healing process, and you're going to be laying down tissue, scar tissue, connective tissue, kind of haphazardly in a way where when you go to provoke it again, it might just re-tear and you're starting from square one again. So you will not know until you put yourself in that scenario again. And the more work you do early on, even if you're not feeling pain, you will have better outcomes, more resiliency to re-injury.
Yeah, an example I like to use with this is like the classic chronic ankle sprain. Someone always, has sprained their ankle a dozen times or whatever. And you take a look at the typical rehab and it's like, okay, stay off of it until it doesn't hurt, it's not swollen, all that kind of stuff. but there's no rehab process. There's no manual therapy often. There's no rehabilitation exercises. There's no return to sport criteria. So basically people just don't put weight on their foot because that's what hurts. They don't do that for 6 weeks. They get detrained. As soon as they go back out on the field because they don't have any more pain, they're stepping right back to immediately where they were, and they roll their ankle again. And they have this recurrent thing over and over because, yes, the pain was gone, but we're not doing the thing that causes the pain, right?
Yeah, they haven't rehabbed the neurological response to changes in posture and position. And it's not just back on playing field, right? It's
or anything, activity.
Miss Jones, walking down the steps again or whatever, right?
Yeah.
So they it feels better because they've laid down so much scar tissue and they haven't irritated for so long. Yeah. And then they go and do the first thing and they haven't rehabbed it properly, and A, it tears, and B, everything goes past anatomical integrity as soon as they put stress on it before that neurological response can be activated.
Yeah, and I would argue that you injure where you got the weakest link in your chain, and before that injury ever occurred, unless it was like super traumatic, that was probably a weak spot for you. That was an area that wasn't holding up its end, and that injury was likely, bound to happen, I want to say, or would have been something that happened at some point in your life. And now you have the opportunity to go, okay, this is where I'm weak. Now I have an opportunity to fix this and make it stronger than it was prior to the injury, because maybe if I didn't get injured now and deal with it, I would have had arthritis down the road from a joint and a mechanical system that was working suboptimally.
I agree. And that's a great thing with that pain comment too, is that pain's always the last thing to come on, first thing to go away. You can't use it as a guide, and arthritis in your ankle would be a perfect thing, right? Never feels bad. You're using it improperly your entire life. You don't even know. Maybe you've had these ankle sprains, you're putting pressure on it, and then all of a sudden the pain just shows up out of nowhere. It's like, well, no, you've been wearing it down your whole life kind of thing.
Yeah, prior to that, you might have had loss of range of motion, stiffness in the tissue, less neurological control for speed of changes.
Adaptation,
adaptation to change in posture and position of challenging there. You've had all these other things happen, but not really pain. It's the classic heart disease analogy, right? It's like you've had heart disease for years and then finally you have a heart attack. Yep. Well, okay, the pain's the final stage. Come on, the pain's the first thing to go away. It didn't mean that you've gotten rid of the heart disease yet, right?
Yeah, and people that are like, well, how can people be so unaware of their own bodies? And I also want to point out that
they are, though.
We are, especially as a society, because think about this. We walk on flat ground 95% of the time. If we think from an evolutionary sense, we would have a lot more of, a hand on the pulse of our body if we're climbing hills, walking on uneven surfaces, moving around in a changing environment.
Yep.
And so all that stuff would bring a heightened body awareness, but we're deprived in today's culture. And you go to the gym for an hour and you think that's going to be enough to get a full appreciation for what's going on in your body, but it's probably not.
Yeah, no, totally agree. And it's funny you say that, because if I have a patient that has almost any lower body stuff, especially ankle, especially knee, yes, maybe they're at the stage where they don't hardly notice it with anything. But going up and down stairs, going up and down a ramp, going for hikes, that little bit of uneven stuff that we don't think about, that's actually pretty provocative to a lot of people because they're not used to it.
Yeah. Okay. So then if pain isn't the best way to measure your improvement, let's help you guys get an understanding of what is. And so first thing on our list was range of motion. This is huge. And to be honest, you might not have had full range of motion prior to your injury, but going back into sport, you want to have at least what it was prior to the injury, and symmetrical would be good, right? Try and get the same as the opposing limb. And this is a easy one to start with if you're like, I don't know where to start with my rehab process.
Yeah, where am I kind of thing.
Yeah, well, how does it feel when you go through a full range of motion? Pick a joint. What are the ranges of motion that you could possibly put it through? And what does that feel? If it doesn't feel like a nice gliding movement, then start there.
Yeah, you want to obviously take it to the pain range, right? And sometimes, you try to work that motion there. It's a classic thing that I do with patients who have OA of the knee, right? Every single day, you have to go into a full squat where you weight the knees as much as you can. You want to try and hold that for as long as you can. It's actually discomforting when you come up from it, but almost exclusively 100% percent of the time, patients about 2 to 3 weeks later say, "Wow, like I can actually full squat now. Like I can actually go down into that full position, and it's now painless." Right?
They've been avoiding it. They've been avoiding it because it was painful. Yeah.
Because they went into the pain range and worked that range. Now, one of the things you want to talk about with all of this is that when we talk about things that you can do, if we're going to talk about injury rehab, we're going to talk about intensity, duration, right?
Yeah.
That stuff. So you have to, and one of the criteria we go by is that you can't have pain that's worsening, or you can't have pain that it lasts longer. So that's what I talk to with patients when I put them through these types of things, is that you should be, if you're going to work in range of motion, we want to push it. We want to go into ranges that are challenging for us and try to restore that motion. That's really important. We just don't want to have residual pain.
Mm-hmm.
So
after you're done.
So in other words, like after you're done, you're sitting there going, "Ooh, boy,
it still feels the same.
That doesn't feel very good now, right?"
Yeah.
Or while you're doing the exercise, you don't want it to get worse, right? Other than that, absolutely you can go into that pain stage, right?
Yeah. So, when you're rehabbing, if somebody's having a 2 or 3 out of 10 discomfort, like okay,
it's fine. Yeah.
But is that lasting? Do you feel better afterwards? This is another one. Like, do you feel better afterwards? Like, could you now do a squat more comfortably than you could before? And if you can't, pick something that might have been aggravating. And if it's worse off, then you're probably not doing the right things.
Yeah.
Yeah. You can't rip the scab off.
Yeah.
Right?
Yeah.
Don't
aggravate it further.
Don't rip the scab off.
You don't want to abuse the residual. A little bit of discomfort during is not not abnormal.
It's not out of the question. That's what I tell people. I'm like, look, you hurt a tissue. Maybe it's a muscle. Every time that muscle contracts, it's going to hurt. Like, that makes total sense. And so as long as that's minor, as long as that's under control, as long as we kind of create that controlled environment, like, it makes sense that it's going to hurt when you use it. That's the definition of the injury in that case.
And in fairness, oftentimes it's just scar tissue has attached itself to pain.
Just popping,
right?
Yeah.
So it's basically firing your pain signal. It's not even...
It's not even actual tissue damage. Yeah.
Right.
I would like to make an addition. So let's say you do have pretty much full range of motion in a joint, relatively full. The next stage you could do further along is, could you move that joint while keeping other joints stable? Yes. Right? Like, could you bring your arm overhead without bending your elbow? Could you bring your hip backwards without flipping your pelvis forward? Like, if you can keep, that's a good idea of what stability is. If you can move one joint without grossly affecting the next joint, you're in good shape.
Yeah, I agree. I totally agree with that. And that's something that even normal, healthy people sometimes have an issue with. Yeah. It's like, no, extend your hip, not extend your lower back. And so I would argue, if you have that awareness after the injury of understanding, my shoulder hurts, but my elbow doesn't hurt, this is what allows me to kind of separate the two in your mind. Yeah.
Oh yeah. Can you bring your arm overhead without extending your low back?
Yeah. Like, or whatever.
Lots. Right? We could go on for days, but just think about that.
Yeah, guys, that's going down the rabbit.
That's advanced.
That is going down a rabbit hole. That is not an overview of rehab and return to sport, right? Because now we're looking at, like, we're looking
true
at
mechanics,
efficiency of the system. Yeah, that's just not.
However, people should understand that is a thing that you may want to consider.
Yeah.
Okay. So moving on, we go with about 90% strength of the opposing limb in order to get back into a sport. And when we say sport, minimum. And when we say sport, we mean like you're doing something that is like maximal effort or is unpredictable. Like if you play a soccer game, that's completely unpredictable.
Uncontrolled environment versus controlled environment. Yeah.
Exactly. And that can be hard to measure. And this is one of those things where like it helps to have an expert with you 100%. But yeah, people can.
I think the conscientious individual nowadays has to work with a health professional to help them rehabilitate an injury to do it properly, right?
Yeah.
You can't just do it yourself, right?
Because you can't. It's like a coach in the Olympics, man. Even the best of the best have coaches. Like,
yeah, you just can't fix it properly without having
not well,
person with you, right? Yeah.
Not well. Okay, so 90%. And when we do muscle testing for patients, it's more than. It's more than pushing weight around. Yeah. It's when you activate a muscle, does it fire immediately? Is the power delivery steady? Can it match my counter pressure? So the quality of how that muscle engages is also a thing, and that's another reason why you need an expert there.
Yeah, because it's hard, right? Like you could, go on the one leg extension at the gym and be like, okay, this is the weight that I'm doing. This is the weight I'm doing on the other side. Those are about 90%, right? It's like, okay, but yes, the way that you're, compensating the way that you're bracing the rest of your body. Like you're not actually doing it the same both ways.
Yeah.
So this is another reason why you got to work with a health professional. I mean, you're looking at somatic inhibition. So are we looking at the tissue is actually not has lost strength or has lost endurance, or is it a somatic inhibition like is it a myogenic inhibition? Is it an arthrogenic inhibition? Like all these little things that your health professional knows and can work on and can actually be able to decipher and investigate and get you going down the right path. Analyzing the movement patterns, analyzing your myofascial sequencing, your muscle sequencing, you're looking at your biomechanical movement patterns, and that's the rabbit holes.
It's a super good point, and basically super good point. What he's referring to is like, is your muscle weak because you're actually weak? Is there a trigger point or a strain in the muscle that's telling it to turn off? Is the joint mechanics all rigid and not allowing those muscles to fire because they work together? So that. Sorry to steal your thunder. I just thought maybe I can make that more palatable. We understand you're super smart, Greg.
Yeah, Mr. Rabbit Hole himself over here.
Right? Okay. So how about no open wounds or swelling? If you're completing an exercise, we don't want that knee to blow up with swelling.
Well, you can't have recurrent swelling, right? Because that's the irritation of the tissue, right? Yeah. And then the other one is no instability, right? Yeah. So, like if you have an ACL deficient knee, well, I'm sorry, but if you're going to go back to sport, you actually have to have a brace that's a multi-directional stability brace, right? So, anyway.
Yeah.
But those are classics, right? You can't have recurrent swelling because recurrent swelling
something's still going on here.
Yeah, that you're irritating it. And the second part is that instability piece because you're gonna cause a catastrophic injury.
And that's a great example. That instability, ACL or ankle, same thing. People are like, well, it doesn't hurt. It hasn't hurt me for a long time, but your ACL is blown out, so you need to put some sort of stability in there.
So I should preface it too, is maybe like if you have an ACL deficient knee, you don't necessarily need a knee brace, but you need to necessarily go through the rehabilitation and the strengthening and neurological control movement patterns that provides the same stability as a knee brace. That goes down another.
You got to make your own knee brace with your own tissues, essentially.
And understanding that stability or balance is part of the rehab process. Like, could you single leg stance? Could you do a half squat on a single leg? Like
again, compared to a single leg extension, you might be like, hey, just as strong as the other one. Right. And then when you go to stand on your ACL deficient leg, you can't do it. Yeah, that's a deficiency.
Totally. And this is why I think that stuff like calisthenics or yoga are a great way to kind of bridge the gap for rehab, because now you're learning how to use your muscles to contract together to keep a joint stable and steady, right? And that's a super important part of preventing injury.
Can I just throw a common example out there for an ankle injury of what we do?
Yeah. Go nuts.
So somebody has an inversion sprain. So they rolled their ankle, right? And so you end up tearing a couple ligaments. One's called your okay. Shut me off the rabbit hole.
That scared me.
So you'll tear like a little ligament on the outside called your lateral calcaneofibular ligament. Then you'll start to tear another one a little bit called your ATFL or anterior talofibular ligament. Not completely, but this is what the damage you do. This
is the grade 1, 2, and 3 for the record. This is kind of how they grade it.
Yeah.
Yep.
But you're not just tearing those ligaments a little bit. You're also probably, irritating, damaging the tendon of the muscles on the outside part that are called your fibularis muscles. Some people might know them as peroneal muscles. But then you're also jamming the inside of the ankle joint complex. So you might be causing like a crush injury to the joint capsule on the inside. So and then you're also, the nerves go through there. So you're kind of straining and damaging the nerves. So one of the things people will do is they'll rest their ankle, or they'll wear an ankle brace, and they'll just, everything will start to get better, but they don't really ever challenge the balance and coordination. So to put it this way, if you were to stand on one foot, you'll notice that you're wobbly. And you're wobbly because basically you're going to, in slow motion, there's, when you start to wobble, lean to one side, there's a signal that's sent to the brain to say, hey, dummy, you should contract a muscle or else you're going to fall over. That signal goes back down. Now, this is for simplicity's sake.
But this is basically what happens.
It actually says dummy.
Yeah, for all you nerds, it doesn't go all the way to the brain. Okay? But there's a signal that's sent down that basically says contract that muscle because you're going to fall over. And then you're going to go the other way. And hey, there's a signal. And then it contracts the other muscle. And in real time, it just looks like a wobble. the thing is that neurological reflex system becomes sluggish if you actually damage the nerve system, right? If you damage the nerves from doing an inversion sprain or rolling your ankle. If you don't rehab the balance and coordination of that, the next time you put strain or stress on that and you're going to roll your ankle, because
Does the same thing.
Everybody knows, like you step off a curve, you go, whoa! I just about rolled my ankle, but
that's that
but they
reflex.
didn't.
That's your reflex pulling it back already.
And so what happens is that reflex reaction becomes sluggish if you don't rehab it, right? Because it's damaged. So you will go past anatomical integrity before the muscles contract to say, "Hey, dummy, bring that back." So ergo, you keep rolling your ankle. So part of the rehabilitation process is actually getting the balance and coordination back, getting the stability back, getting the movement pattern back. So that's where we get back to no recurrent swelling and no instability. You actually have to do rehabilitation to actually get the movement sequencing proper and fast again. Same thing we do with ACLs, but
Just different muscle groups.
Full circle of why I talked about this. So one of the criteria we do is when I test, when somebody has an ankle sprain, I'm like, hey, stand on one foot for 30 seconds.
Should be easy. No problem.
And they can do it with a good leg, and they just can't do it with a bad. So that's one of the criteria we use. Can you stand on that leg for 30 seconds? And then we do a bunch of challenge exercises around that with closing your eyes or bending your head back, taking out your sequential balancing systems. But regardless, that's how we do return to sport, is putting them through challenges and make sure that they have that stability back.
Yep, and that's a great point too with the neurological aspect of it too. Because people think of us as mechanics a lot, that it's like, okay, a piece of meat that needs to be fixed. Like, no. There's a complex neurological interplay. And the way I describe it to people is that if you have an injury, you have that little section in your brain that takes care of that part that was injured. And so if that's a treasure map and that part gets ripped out of the treasure map, that's what's responsible for your ankle. That's your brain's picture of your ankle. It now no longer has any idea of where that is, where the edges are, any of that kind of stuff. But it's cool because we can use the afferent neurons to put input back into the brain. So we're using the ankle, we're doing manual therapy, we're doing balancing, and that's what's slowly redrawing the part of that treasure map. And if it's fully rehabbed, it should act exactly like the other ankle.
Great information, guys. I mean, where else? What other podcasts are you going to get this value?
Honestly, none.
This height of information.
We know stuff.
Holy smokers.
Yeah.
Okay.
Three Stooges going at it.
Yeah. Holy bananas. Okay. No fear avoidant behavior. So the next criteria you want to talk about is there's a psychological impact to getting injured, right? Let's say we have a player that has full range of motion. He's got 100% strength in that limb. There's no swelling. There's no absorbable. He can balance. There's no open wounds. But every time he plays football and you just get in that certain position, somebody goes to tackle him, you just shut down, right?
Yeah.
You need to have confidence in your ability to play. And part of that is, well, one, you got to talk to yourself and get there. But part of that is you have to reintroduce yourself slowly in a graded way to a point where you can do those sports-specific requirements in a controlled environment. You can, take a tackle in practice just like you would in a game, so that when they reintroduce you to the game and it happens, out of nowhere, unsuspectedly, you're not totally thrown off guard.
Yeah, and that's a good point too. You might think of oh, he's scared to go back and get injured, and kind of as a lame thing or whatever. It's no, this is a neurological response.
Yeah.
It's almost like a PTSD thing that as soon as those joint receptors in that joint feel the same way that they did when they were injured, they're just going to shut off. And it's a reflex. It's not he's not ready yet. It's no. Neurologically, he's not ready yet.
Could be both, yeah.
It also could be both.
Could be both.
It could be partly both.
And that second of hesitation might have cost him the play.
And that's what gets you injured in the first place, right? Any amount of hesitation, you're not in it. Yeah.
Are you guys cool if I talked about sort of the rehabilitation pathway? We're talking about duration, frequency, intensity, because that kind of comes into play on it.
That's definitely the next. Yeah.
Can I do that?
Go nuts.
Okay. So when we rehab a classic injury, name your injury, and we're basically starting rehabilitation, and what we do is we need to back within a controlled environment, right? So we're not going uncontrolled. And then we reduce intensity, frequency, duration by 50%. I don't worry too much about frequency, but duration, intensity, 50%. So basically, let's say you're doing weights. You're just in the gym doing weights. We would reduce the number of sets by 50%, and we would reduce the weight, the resistance by 50%, okay? And so they would go back and they would do that session in a gym, controlled environment, again, 50% weight and 50% sets and reps. And then we look to make sure they don't have residual pain or they don't have pain that's worsening, period, full stop. You get through that, next session, the first thing we increase, duration. So we're going to take maybe 75% and then maybe 90% and then 100% duration. Intensity is still at 50%. Okay. So what you do is you build up the foundation of motion, build up the foundation of movement patterning before you load the system higher.
Increase the volume.
Yeah. So the last thing we increase is intensity, right? So we want to get that foundation of movement. And then once we get them back to full intensity, we get them full duration, now we can kind of take them to uncontrolled environments, right? So we're in a controlled situation and now we're in an uncontrolled situation. That's where we're talking about, kids getting back to practice or people getting back to whatever physical activity they're doing. And we build that up at 50, 75, 80. So that neuroplasticity, when we talk about the brain's adapting to being able to participate in a sporting event, if we can take them through that practice criteria where we build them up and get them more comfortable in taking that hit and get them more comfortable in being in that uncontrolled situation, and then they get those big hits and they go, oh wow, actually I can deal with this. That's where you kind of get through that psychologically ready to play, right?
You build their confidence by letting them do it themselves.
Because you know that the system can now handle the load, even in an uncontrolled environment.
Yeah, you set them up for success by making them do easier things and then step by step, and then they're back.
And I got to tell you, throughout my career, I've learned this obviously in over time, but I have failed so many times, Like I've had so many kids that want to go back to soccer practice and they go, Dr. Uchez, can I just, we're going to scrimmage, but we're working on plays. Like we're only going at 50% intensity. Can I go and just do the drills with them? Like just so that, I can just be in on. I'm like, yeah, as long as you're only going at 50%, but it's an uncontrolled environment. So what happens is they're going at 50% until somebody kicks that ball just out of their reach. And then, I get it, right? Boom. I've had that happen in basketball and in soccer, like so many sports where we put them into an uncontrolled situation without building the foundation of movement there, and I just screwed them up. So I guess take-home message is controlled environment, duration and intensity and frequency, 50%. Last thing you increase is intensity. You build the foundation of movement up. Please don't start to go harder. Build up more. I've had sprinters that said, I did 660s at 60%. It felt so good. That sixth one, I decided to take it up to 75%. Yeah, and then they blew the hamstring again. It's just, you need to build up the foundation of movement before you actually load that system more.
Pyramid's only as wide as its base. Pyramid's only as wide as its base.
Yeah, this is a hard one. And sometimes you just need to humble yourself for this one, especially if you're not in pain, because what's the worst that could happen? Like you're going to go have a workout, leave feeling good, not re-aggravate your injury, and as opposed to you missing out on an extra 20% intensity.
Yeah.
This is a hard one because also people go to the gym and they don't want to a lot of times go for a half hour.
Yeah.
Yeah. But
they don't want to go and see what they can do. They don't want to test it out. That's okay,
because then you're going to turn around and you're going to go 0 minutes.
Because you're injured. I agree. I totally agree. But that's what people are thinking. I feel that.
And on the same note, if you're not doing this, then take a step back and recognize it. This is why my injury's not getting better.
Yeah.
Okay, you got to be able to link the two together and go, okay, what did I not deliver on today?
Yeah.
And it's tough because I agree. I hate telling athletes that, or people in general, just
they can't
or they shouldn't, because I'm totally on board with doing something at every stage of injury, and it's good to acknowledge that. But yes, it's a step-by-step process. And so maybe a final note to end on, unless you want to go into bone fracture healing.
If we want to touch on it, I'll spend a minute.
Yeah, I think this would be useful just to illustrate what healing times are for different things. And it depends on the tissue, depends on the injury. But this will give people a little bit of a better idea of kind of like what to expect.
So when you go through the traditional healthcare system and let's say you have a fracture in your wrist. Now we're talking like simple, non-convoluted, right? We don't have a compound fracture. It's just a simple fracture, undisplaced fracture. In your wrist, they probably put you in a cast for
4 to 6 weeks, something like that.
6 weeks, right? Yeah. Probably 6 weeks if radial or ulnar fracture, something like that, right?
Yeah.
But the fact remains that healing rates, like again, uncomplicated, simple fractures, we're looking for a finger is 2 weeks, right?
Yeah.
We're looking for a metacarpal 3 weeks, 4 weeks into, looking into if we're looking at an ulnar radius,
depends how big it is, depends on where it is.
Yeah, 5 weeks probably into the humeral head, and we're probably looking at maybe 6-7 weeks once we get into the neck of the femur. That's because it's a big ass bone.
Area.
So the fact is that everything is shifting from stability and immobilization to
activity, keeping
protect
it moving,
and optimally load.
Yeah.
Right. So if you got a simple fracture in your finger, like should we be casting you 4 to 6 weeks? We're knowing that it heals in 2.
No.
Right. Knowing for an example, my kid had a fracture where he blocked a slap shot from the point, had his hand down, and it basically hit the dorsal aspect of his metacarpals. And he had a fracture right at the growth plate, but he had a fracture there. And of course,
looks bad.
Yeah, it's swollen and everything.
Like a baseball
and they wanted to put him in a cast for 6 weeks. I'm like, zero chance. Yeah. And I get why. It's a liability piece. They're not going to see this patient again. They're, lowest common denominator. There's a whole bunch of pieces here. But with me in there, and I can clinically correlate. Yeah. So anyways, we'll get into that in a sec. But like I said, no, we're going to put him in a wrist brace, right? Yeah, sure. And then I take it off. I actually did like soft tissue work, getting around the region.
That day,
I had him doing contrast. I had him, you know what? And long story short, I mean, I clinically correlated. I put bone pressure on, palpated the area, had him go through range of movement testing. And the fact is like within 3 weeks, I had him playing again. There's no pain. There's no and I re-imaged like nothing. Like it was there. He was good to go back, right? But the thing is that you need, and I have done this. I'm almost at the point I could say 100 times, right? We're maybe triple digits now with people who've had a fracture where I've said, okay, that's just too long. Yeah. Like the amount of damage, the amount of damage you're doing by complete immobilization for that period of time is going to do more long-term detriment than it is by let's just protect and optimally load. Like the bone needs some degree of healthy stress to heal. Yeah. And if we don't do that, it's going to take so long for you to get this back to where you were pre-injury. So, but yeah, again, protect, optimally load as opposed to rest and isolate and stabilize, right? So, fracture healing, right? 2 weeks, 3 weeks in the forearm, 4 weeks, I guess 2 weeks 3 weeks in the metacarpals and metatarsals, 4 weeks into the forearm, 5 weeks into the
basically the size of the bone, more or less.
It's the diameter, guide. But yeah, man, when we have finger injuries, we're 2 to 3 weeks we're healed, like. I get it. I get it for all, again, the nerds out there. We're remodeling for as much as a year after the tissue. I get that. But if you can protect and optimally load that bone tissue as it's healing with, we don't want to put stress on so we're delaying healing process, but you allow some freedom of motion and you allow the muscle tissue and supporting structures to work, you're going to cause less wasting away the tissues, and rehab's going to be so much faster. I mean, we see this in any type of, let's say you're going to get a knee replacement or a hip replacement. Prehab reduces rehab in half, right? If you're healthy going in, you're going to rehab way faster. This is no different than if you do it with a fracture. But again, you have to protect and optimally load, and I don't want to give medical advice out there considering they should be immobilized for, someone would say is 6 weeks. But work with somebody that knows what they're doing.
Yeah, and so in overarching principles, that's where there's a bit of nuance to this, and that's why they would kind of generally say, okay, 6 weeks, don't move it. And okay, that's an option, knowing that your body's going to heal best if you can slowly increase that stress. And in a sense, we are doing harm by overprotecting an injury. Yeah. We want it to slowly develop under stress so that it can be more resilient to stress. And overprotecting it, okay, you Chaz, go nuts again.
Please consult your healthcare professional before embarking upon any.
These are general.
Self-directed.
It's great. This is
removal of a cast.
These are general recommendations.
Yeah.
Each person is a specific case.
Yeah.
We're just trying to match you so that you understand in the healing process what section you're in. That being said, part of what he's saying is you do need to retest. You need to, somebody needs to be doing that testing to actually see where you are on that day.
Needs clinical correlation. So please consult
to.
your healthcare professional before taking any drastic measures and removing a cast and getting all
Especially
that
stuff like that. Yeah.
And
we're not telling you to do that. Don't take your cast off.
Don't do that,
here.
no.
Yeah.
And I just want to close with a few other remarks. So for one, your healing timeline will also reflect your overall health. So if you're somebody that's not getting enough sleep, not dieting well, just in general in poor health, you're going to take longer to heal. Your body is a self-healing mechanism, so give it the best chance at healing appropriately by taking care of yourself.
Yeah.
And then lastly, the thing is, like, I get it. Sometimes it's playoff day and you just want to play and maybe you're not where you need to be you're not meeting that criteria necessarily. And that can be a conversation you have with your expert, knowing that there's the potential to make it worse, and that there are potential risks involved with playing through it anyways. But at the end of the day, if you're an adult and you understand those risks,
yeah, risk benefit, always risk benefit
ratio. Yeah, you can weigh those risks, but overall, we really try to aim for the criteria unless it's like it's a real, it really needs to happen. Yeah. Okay. Well, great podcast, guys. Great session. Nice. Thanks for all our listeners. Please reach out at any time with any further questioning. You can find us on Instagram on move2improve_pod. And that is all.
Thanks, guys.
Good stuff. Thanks, man.